very good morning to one and all. The second talk of the day is on robotic surgery in live donor liver hepatectomy. So we'll be covering this topic in the following heads, following a brief introduction and a historical perspective. We start looking at what are the advantages of the robotic platform. Why are we even discussing robotic hepatectomy, live donor hepatectomy? What are the issues with this which have prevented a widespread adoption of this technique, and what is the skepticism associated with it? What does the evidence say? What amount of evidence do we actually have? And then finally, how do we summarize our existing evidence today? So the picture here is for the non-surgical audience. This is what a robot looks like. So on the extreme right, this what we are seeing is the console at which the main operating surgeon sits and operates the robot. This is the robot which is placed at the bedside of the operating table. These are the 4 robotic arms which are designated R1, R2, R3 and R4 for ease and clarity of communication. This is the monitor for the assistant team as well as for the others in the operating theatre along with the work cart. So as we all know, liver transplantation is the cornerstone of treatment of end-stage liver disease. Organ shortage in deceased donors has led to the emergence of the live donor liver transplant program, which is the primary program in our country. Central to this is donor safety, which is of paramount importance. Open donor hepatectomy remains the standard of care today. But this open donor hepatectomy is not without its set of complications. There is a minuscule but definite risk of mortality of 0.2 to 0.6%. Morbidity ranges from 20 to 40%. And nearly half of this morbidity is contributed by the size of the incision in terms of pain, wound infections, scars, hernias, or subacute obstruction. In fact, the 2 most common donor complications that were documented in the A2ALL study were infection and incisional hernia, both of which are related to the size of the incision. So technical advancements in the later half of the 20th century saw the growth of laparoscopy, and it was readily adopted for abdominal surgery. With further increasing expertise, laparoscopic liver resection started being attempted. The first completely laparoscopic left lateral sectionectomy for living donor was performed by Daniel Cherky in 2002. It took nearly a decade for a left laparoscopic left hepatectomy in a living donor to be performed by Troisi. While the first laparoscopic right hepatectomy is credited to Han from Korea, he published his results only in 2013, simultaneous with Olivier Soubrain, who reported the first laparoscopic right hepatectomy. So with this itself, we can see that we are a decade from the first laparoscopic right hepatectomy, and laparoscopic donor hepatectomy has not taken up as expected. It's a formidable task. It has a precipitous learning curve for the whole team. And what is important for a laparoscopic donor hepatectomy is that you need a team which is simultaneously well trained in open donor hepatectomy as well as possesses advanced laparoscopic skills. Both of these are niche areas, and it's not usual to find teams which possess both these qualifications. Robotic surgery came up in the first part of the 21st century. The first robotic right donor hepatectomy was reported by Giulianati from the University of Illinois, Chicago in 2012. And thereafter, there have been several series attesting to the feasibility, safety, and advantages of this robotic surgery. So if we look at the advantages, why are we even discussing robotic and not laparoscopic? This is because it offers unique advantages. It mirrors open surgery, the first thing. So it takes away the inherent disadvantages of laparoscopy. So it provides us with a very stable, high definition, 3-dimensional image which reduces overshoot. The machine has a tremor filtration effect, so it abolishes the effect of hand tremors. And the most important perhaps is the 360-degree freedom of movements akin to the human wrist, which is lacked in laparoscopy, making suturing very difficult there. So this 360-degree movement, in fact, affords that robotic suturing in potential spaces is actually sometimes easier even when compared to the open surgery. So suturing of the duct is easier when you're talking about robotic surgery, whereas one would tend to clip the ducts when you're talking about a laparoscopic surgery, therefore making it safer. Another aspect of the advantage of the robotic platform, which is common, it shares with laparoscopy, is the availability of image integration. So you have real-time fluoroscopic guidance when you inject an ICG. You can clearly demarcate the line of transection, which along with the magnification it offers, allows a better hemo and biliostasis. It also, because of the ICG, you can delineate the biliary system and you have a very precise and safe division of the bile duct. Also, robotic platform is purported to have a shorter learning curve compared to laparoscopy. Then there are other advantages which it shares with the laparoscopic platform, which are mainly attributable to its minimal access. So patients are likely to have lower pain, shorter hospital stays, lesser blood loss, faster return to normal activity, better cosmesis, lower rates of incisional hernia, and as also of subacute obstruction. This is an image which shows the traditional Makuchi incision and the scar following that in open surgery. These are the scars of laparoscopic and that of a robotic surgery. However, it is not as if the robot is perfect. There are several issues with it which have deterred the widespread adoption of robotic liver resections or robotic donor hepatectomies. So first of all, liver resection is an extremely complicated procedure and has evolved with its own set of instrumentation for liver transection. So most donor programs would use CUSA for liver resection, and this is yet to be integrated into the robotic platform. So this entails that you have to use a laparoscopic port and another bedside surgeon experienced in liver transection has to be present for doing the liver transection. Secondly, most of the earlier staplers were not integrated. Now they are integrated into the robotic platform, but there are still 3-road staplers. You don't have 2-road staplers, so they take up more space as well. Then there are issues that are specific to the robot itself. So as we've seen in the photograph, the robot is mammoth. It takes up space. It's cumbersome. It is going to take time to undock and undock both at the operating table. So this undocking is very important because in the face of an emergency, if there is a torrential bleeding, it's going to take time for conversion. And it's actually one of the main fears that had deterred the uptake of this program is that what if there is a bleeding and the time it takes may result in an adverse event. The third issue with the robotic platform is a lack of haptic feedback. So what is a haptic feedback? So if you talk about open surgery, you can touch the tissues, you can feel the tissues. This is not there in laparoscopy. But still, you do have a feel of a tissue through the instrument. You can make out your tissue is soft, hard, friable. When you tie a knot, you can adjust the strength of the knot, the pull on the instrument. Now, this is not there in the robotic platform because you are working on a console. So you don't have any idea about how tissues are friable. It's only with experience. So novice surgeons are liable to cause trauma, injury, and there may be either the knots may be too loose or too tight, resulting in strangulation. Now, so there is some promise that this lack of haptic feedback is going to be addressed in future generations of the robotic systems, but as of now, they do not exist. The next issue being that this robot is going to be a resource intensive thing. So when you do start off with the robotic technology, it's a learning experience for the whole team. So you need a team which has a good experience in your open liver donor hepatectomy, and you need experienced bedside surgeons. It's not just the main console surgeon who's important. You need equally experienced bedside surgeons who would be handling the non-robotic energy devices like CUSA, and those who will be responsible for conversion if there is any bleeding or any eventuality. And then finally is the cost of the robot, something that is the elephant in the room which needs to be addressed. There are further other issues. So living donor transplant is very unique because here you have two lives at stake. It's not just the donor, it's also the recipient. So being safe on the donor is not sufficient if the graft is of not use to the recipient. So as we have already alluded to, the risk of bleeding, the time it will take to convert, and then early reports from the laparoscopic era suggested that there were risks of biliary ductal stenosis or hepatic venous stenosis. So these are risks that are there on the donor side. As also, it is universally documented that there's going to be longer warm ischemia time with the robot. This may translate into greater rates of early allograft dysfunction. There may be higher number of biliary complications. Further, the prolonged pneumoperitoneum because of the longer operative times may translate into poorer liver regeneration also. So we'll see how many of these are addressed in the current evidence. Further, this is a new technique. It's still in its infancy. The technique is not yet standardized. The learning curve, it's believed to be shorter, but we do not know exactly what is the duration of this learning curve and what effect does it have. Further, with increasing experience in open live donor hepatectomies and an ever-increasing donor shortage, so you are taking up more and more complicated cases with more and more variable anatomy, and if you start off a robotic program, this is unlikely, at least in the beginning, to be able to benefit these set of patients who will still require an open hepatectomy. And then finally, one of the most important aspects are if and when there is a donor mortality. It has immense ramifications for the institute, for the team, for the program in general, leading to even shutdown of the program. And it is this fear that has actually prevented the reporting of anecdotal negative experiences even when they have happened. And so the literature appears to be overly optimistic even though the word of mouth suggests that there have been mortalities. Look at the evidence. Chen et al. First reported a series of 13 robotic right lobe donor hepatectomies in 2016. They compared it with their own experience of 54 open right lobe donor hepatectomies. They had 0 conversions, similar rates of blood loss, complications, recovery of liver functions, and hospital stay as well. What was documented was a longer operating time, but the advantages that were noted was lower analgesic requirement in donors and a faster return to their normal activities. The recipient side had similar rates of allograft dysfunction, complications, and 1-year recipient mortality function. And the cost, however, was higher in the robotic arm. And they concluded that the robotic right lobe donor hepatectomy was safe and feasible, and probably had an advantage in terms of faster return to activity. So early in your learning curve, you are likely to choose donors with a more favorable anatomy, which may result in more favorable results. In order to overcome the selection bias, the group from Saudi compared robotic and open right lobe donor hepatectomies and did a propensity score matching analysis. So they compared 35 robotic right lobe donor hepatectomies with 70 open right lobe donor hepatectomies, matching them for the donor's age, sex, gender, and BMI, and the recipient's age, gender, BMI, MELD, and indication. So as in other reports, operative times were definitely longer in the robotic arm, but they found that with increasing number of cases, the operative time progressively reduced, and there was a rapid shortening of the learning curve. Even they did not have any conversions. Warm ischemia time was longer in the robotic arm, but the blood loss was significantly less. They documented less analgesic requirement and shorter hospital stays, without any significant differences in terms of donor or recipient outcomes, overall complications. So they concluded that a robotic right lobe donor hepatectomy is safe, feasible, and reproducible with significantly reduced blood loss and a shorter hospital stay when compared to the open procedure. So this is about the right lobe hepatectomy. But robotic has also been attempted for the left lateral sectionectomy, where surgeons have more often been comfortable with the laparoscopic arm. So the same group reported their results in robotic and laparoscopic. So they compared the first 25 robotic procedures with the first 25 laparoscopic procedures and the last 25 laparoscopic procedures to elucidate the effect of the learning curve. So they found that the robotic procedures, the first 25, did as well as the last 25 laparoscopic procedures, and differences were noted primarily with the first 25 laparoscopic procedures, whether it was in terms of the blood loss or hospital stay or analgesic requirements. The operative times were longer with robotic, but they progressively reduced with more number of cases. Warm ischemia time continued to be longer in robotic, and the recipient outcomes were similar. So what they found was that when you compare with the laparoscopic arm, after the learning curve of laparoscopy has been crossed, the robotic did not appear to offer a significant advantage in the left lateral sectionectomy in living donors, enough to justify the cost of the robotic program here. So this is one of the largest single center data from the same group, 1724 donor recipient pairs from a prospective single center transplant registry, of which nearly half of these were robotic, 1/3 were open, and 10% were laparoscopic, with 60% adult and 40% pediatric data. So this is a very interesting graph. Though this represents the volume of hepatectomies at this King Faisal Institute in Saudi, this is what is the general trend which has been seen globally also. So there were a steady number of open transplants which were being done. In 2012, the laparoscopic live donor hepatectomy was introduced. But we can see that the curve has not increased significantly over the next 6 to 8 years. On the other hand, robotic live donor hepatectomy was introduced somewhere around 2017 to 18, and the number of robotic live donor hepatectomies increased steeply. So even though the total number of transplants have also increased, if we omit that part, we see that in the same time, the total number of laparoscopic live donor hepatectomies and open live donor hepatectomies have both decreased, and by about 6 years, they had shifted to completely doing robotic live donor hepatectomies with 0 open donor hepatectomies. So if you look at the donor characteristics and outcomes, this is a busy slide. Of importance here is that laparoscopic arm was predominantly used only for the left lateral sectionectomies, and when we compare, the robotic arm, as in all other procedures, was found to have a longer operative duration. It had lesser conversion rates compared to laparoscopy, but the estimated blood loss, the overall morbidity and the hospital stay were all better in the robotic arm and in favor of the robotic arm. What they also found was that the incidence of biliary complications was minimum in the robotic arm compared to 9% in open and 11% in laparoscopic. This they attributed to the ability to do an intracorporeal suturing and a better and precise transection using the ICG guidance, which lends a few more millimeters of duct. It reduces the risk of biliary stenosis on the donor side and reduces the number of graft openings on the recipient side. So they found that the robotic surgery was one of the major predictors, strongest predictors of morbidity for the donors. So in order to eliminate the effect of selection bias, they compared donors from an era when only open donor hepatectomies were being performed with an era in the end when only robotic donor hepatectomies were being performed. And they found that the operative time continued to be longer and all the other parameters, that is the blood loss, the comprehensive complication index, the overall morbidity and the hospital stay continued to favor the robotic arm. If we look at the recipient outcomes, now this is again something very interesting. This is also, I'm sorry for a busy slide, but what came out was, for the first time they showed that the benefits of the robotic donor hepatectomy spilled over into the recipient subgroup. And they found that the overall major morbidity were less in the recipients, both pediatrics and adults. So they found lower rates of infections, lower rates of biliary complications and lower rates of bleeding, which they attributed to a better hemostasis and biliostasis and a more precise transection under magnification on the donor side and a better transection of the bile duct, leading to lesser number of openings on the graft side. And so they concluded that robotic live donor liver transplant was associated with superior outcomes when compared with the laparoscopic and open approaches, and both donors and even recipients benefited from lower morbidity rates, and therefore this has a potential for advancing in the field. So this is a meta-analysis which tried to consolidate the benefits of the robotic versus open live donor hepatectomy. So only 3 studies looked at right lobe right donor hepatectomy versus open live donor hepatectomy. What came out was a higher operative time on the robotic side and a shorter hospital stay. The mortality, morbidity and blood loss were all similar. There wasn't enough data. There's only a single study comparing robotic with lap-assisted donor hepatectomy and only a single study comparing robotic and open in the left lateral segmentectomy, which we've already seen, which was not sufficient for any meta-analysis. So now we come to the much hyped learning curve. So what is the learning curve? So it is an improvement in performance over time or the change in the ability to complete a task until failure is reduced to a constantly acceptable rate. So it is believed that the robotic platform provides a shorter learning curve when you compare it with the laparoscopic. So Chen et al. Found that 13 cases were sufficient for them to cross over the robotic learning curve for right donor hepatectomy. But here, this data is to be taken with a pinch of salt. Why? Because these were these were teams which were already doing not just open live donor hepatectomies in good numbers. They also had 4 years of laparoscopic live donor hepatectomy behind them and 50 cases of robotic liver resections behind them, which would have no doubt reduced the learning curve for the robotic live donor hepatectomies because a lot of troubleshooting has already happened. In a separate paper, they divided the learning curve into 3 phases, that of a novice surgeon. The first 15 cases where the operative time and the hospital progressively reduce. The second 10 cases where you become a trained surgeon and you can take up increasingly complex cases and the blood loss also reduces. And finally, the experienced surgeon with the next 25 to 50 cases where one can venture into a donor hepatectomy. So again, like I said, most teams would say, most of the data suggests that 15 to 16 cases is what you require as a learning curve for your robotic live donor hepatectomy when you compare it with 45 to 60 for a laparoscopic live donor hepatectomy. The confounders here being that most of these teams were already doing their laparoscopic live donor hepatectomies and doing robotic non-donor hepatectomies before they embarked on the robotic donor journey, which would have led on to a shortening of the learning curve. And then further things like the presence of a dual console and a collaborative proctorship can further aid and reduce your learning curve. It's interesting that Professor Rela suggested that there is also a feasibility of directly transitioning from robotic to robotic from the open platform without any experience in the laparoscopic arm in between. However, this is not what most other centers would accept. Then the next question is of cost. This is the elephant in the room. Everybody knows that the robot is very expensive, the installation costs are huge, and even it's not just the installation cost withstanding, even the disposable costs immensely. So they add on close to 1500 to 1700 US dollars, which translates to 1.1 to 1.5 lakhs per surgery more compared to open. In fact, Chen et al. Found that the cost tripled when they compared robotic right donor hepatectomy to an open live donor hepatectomy. So cost effectiveness analysis are lacking. So what we gain in terms of the patient's shorter hospital stay, patients getting back to work earlier, so reduction in the number of dailies lost, the quality of life improvement of the patients, they need to be compared with the economic cost. And yes, if this is getting spilled over into the recipient side, what are you gaining there when you divide it by the total cost? So this is a cost-effective analysis, not from the donor setting, but from open laparoscopic and robotic liver resections. So the blue dot represents the cost of your robotic procedure, the orange is your laparoscopic, and the gray one is your open surgery. So they split the cost as that of the procedure and the hospitalization. So we see that the hospitalization costs for robotic and laparoscopic are very less compared to that for open, but the robotic costs for the procedure are very high, and that continues to drive the total cost, robot being the maximum. So this is a table that summarizes the results of the robotic liver resections which are there in the literature. The largest one is not added to this table. But even though we are seeing about 10 studies here, it is important to note that they actually come only from about 4 or 5 centers. So 2 of these are from our Indian centers, one from Amrita and one from Professor Rela's group. So what we see is that the operative time for a right lobe donor hepatectomy is about 8 to 9 hours, the blood loss somewhere between 100 to 150 ml, and the length of stay being about 7 days, the complications not being any significantly different from the open. So what do we glean from the literature? What are the prerequisites for setting up a robotic live donor hepatectomy program? So you need a very experienced console surgeon. He's the main operating surgeon, who needs to have an extensive experience in not just open living donor hepatectomy, but also in robotic hepatobiliary cases and preferably laparoscopic cases as well. Now this is because, as we've already seen, sometimes the conversion takes time. So it is believed that all attempts at laparoscopically controlling the bleeding should be done before you try to convert. So an experience with laparoscopic surgery definitely helps in progressing your donor robotic program as well. The second you need is a dedicated team, not just of your surgeons, but also of your anesthetists, the scrub nurses, the technicians, everybody. This is to minimize variability so that you can enhance donor safety, improve efficiency, and rapidly reduce the learning curve. Then you need collaborative proctorships and mentorships, along with dual console training. This increases the donor safety and again shortens the learning curve. However, what is not clear is who is the ideal proctor, who can offer mentorship. Next, as is with any procedure in the beginning, donor selection should be restricted to patients with favorable anatomy so that you can ensure feasibility. And there should be a low threshold for conversion, or as suggested by Professor Rela's group, a time-bound conversion in your initial cases may be useful. To summarize, robotic live donor hepatectomy appears to be feasible and safe in experienced hands. A prior laparoscopic and robotic experience is preferable. The published literature is still evolving. It is not mature. It suffers from selection bias. It suffers from publication bias. And most of the experience, or I could say almost all the experiences from the Da Vinci XI platform, so most of the resources have been monopolized there. And it appears that this robotic live donor hepatectomy is more suitable for the right or the left lobe rather than the left lateral segment. The cost is high, but as more and more indigenous platforms develop, this cost is likely to come down. What we need are prospective donor registries with pooled-in data for better data monitoring. And at present, guidelines only consider a robotic live donor hepatectomy to be an acceptable alternative in experienced high-volume centers to a pure laparoscopic live donor hepatectomy, and not something that is a standard of care. And to conclude, I like to quote Thomas Dazel: "What was inconceivable yesterday and barely achievable today often becomes routine tomorrow." Thank you.